Until recently, bevacizumab was our only choice for an anti-angiogenic agent. And that choice is really, as I previously mentioned, a first-line choice in combination with a platinum doublet, typically carbopaclitaxel or carbopemetrexed. Bevacizumab is an antibody to the VEGF ligand. Recently, we saw some data with Ramucirumab, which is an antibody like bevacizumab, but the target is the VEGF2 receptor. So it's a receptor target versus a ligand target. Ramucirumab was studied in the second-line setting in combination with docetaxel versus docetaxel alone, and it met its primary endpoint of improving overall survival. Now, the hazard ratio was about 0.85 or 0.86. P-value was significant, so that's not a home run, but it's a positive trial. And a couple of remarkable things about the trial. This is really the first demonstration in the second-line setting that two drugs beat one, and so that's an important observation. We've known for quite some time in a number of trials that compared one and two drugs that there may be a response benefit, there may be a PFS benefit, but there's not a clear overall survival advantage. This was a clear overall survival advantage, albeit of a modest effect. There was a benefit in response. The response rates, I think, were 13 versus 22% on the 2 arms. There was a very similar benefit in progression-free survival, so it's nice to see all three, response, PFS, and OS, moving in the same direction. The other notable thing about the trial is that it allowed all histologies. As I've mentioned previously, Bev is a drug we avoid in squamous because of the risk of pulmonary hemorrhage. Ramucirumab was studied in all histologies and was not associated with excessive toxicity in the squamous versus non-squamous population. So this does open up the choice of anti-angiogenic therapy for the first time for squamous histology patients, albeit in the second-line setting. The toxicities, like we would expect with an anti-angiogenic agent, there was actually some increase in neutropenia, some increase in febrile neutropenia, some increase in hypertension. There was an increase in bleeding/hemorrhage, but most of that was related to epistaxis, not necessarily fatal pulmonary hemorrhage. In fact, there was absolutely no difference in the rates of high-grade bleeding in grade 5 bleeding on the 2 arms of that trial. So we can rest assured that you may see some increased rate of grade 1, 2 bleeding hemorrhage, which is mostly epistaxis, but not necessarily high grade, and certainly not life-threatening toxicities in this particular setting. So it was recently approved by the FDA in combination with docetaxel in the second line, I think becomes an option. Again, the survival advantage isn't such that, I may use this in all patients. I still think that you have to be careful given the nature of the lung cancer population. It's an older population. It's a population that is somewhat toxicity prone, and we know the toxicities are increased with this agent. I think like bevacizumab, it took us a while to understand the age effect. We don't quite have enough data with Ramucirumab to know all the issues of patient selection. Neither one of these drugs, either Ramucirumab or bevacizumab, has a reliable biomarker, so it's hard to know from that point of view how to select patients. So it'll be interesting to see the uptake of this drug. I'm not, given the very large phase 3 trial, I don't think that there are any undue toxicity concerns, assuming that you select patients well for the use of docetaxel and in combination with Ramucirumab. One of the issues is docetaxel in that setting. It was given at 75 milligrams per meter squared. It's a pretty tough dose in this setting, even though it's the FDA kind of approved standard dose for second-line treatment. I tend to use a lot of weekly docetaxel in that setting, which I find to be better tolerated. And of course, we don't yet have data with regard to the use of Ramucirumab with weekly docetaxel or other cytotoxic agents. like pemetrexed or gemcitabine is commonly used in this setting, or erlotinib in this setting. So there are many questions to be asked about, is the benefit restricted to being used with docetaxel?